So tonight, Professor Narissaporn Chaiprakit will give us the topic. The topic is a surgeon-friendly BSSO by the novel modification of low-Z plastic NM-LowZ technique. So we can't wait to learn from Dr. Jia. So Dr. Jia, please. Thank you.
Thank you very much. Good evening. Thank you, Dr. Pear, for your introduction. Thank you, Dr. Bang Yun, and thank you, ICC webinar, for your kind invitation to me. Okay, the topic is a surgeon-friendly BSSO by the novel modification of low-Z plastic or NM-LowZ technique, which is routinely in my practice for BSSO. Currently, I'm a faculty member at Chaiprakit University, Thailand. I graduated oral and maxillofacial surgery from Chulalongkorn University, and then continue fellowship training in oral and maxillofacial oncology and reconstructive surgery, Peking University School of Stomatology Hospital. I have worked for dental facial deformity, pathology, and reconstructive surgery and dental implant surgery. Here is my university is at Chaiprakit University Langsit Center. The university is located approximately 1 hour drive from the airport, and we are celebrating 90 years anniversary. I also serve as an oral and maxillofacial surgeon at Chaiprakit University Hospital. This is the picture of my hospital. And actually, I'm a fan of Changgang Forum and our professor both in the orthodontics and plastic surgery department. And these are my great memorial pictures in 2015. On October 2023, I also have joined Master Series course. That course is very impressive to me and inspired to me for the A+ results, a motto that's created by Professor Duration. Okay, I would like to have a brief review about the history of BSSO modification. The mandibular osteotomy was introduced by Hurricane for centuries. Then, the osteotomy has been modified gradually to the posterior area of mandible. We have condylar and subcondylar osteotomy, but it's complicated procedure than inverted L introduced by Dr. Wasmund. And then the sagittal split osteotomy created by Dr. Turner and Obligator. Then Dr. Daopong modified lateral bone cut anteriorly toward the distal border of the second molar. Dr. Hansuk and Efker modified the lingual cut at just superior and posterior to lingula to avoid nerve injury. So, Efker and Hansuk modification is widely used nowadays. In Thailand, the BSSO modification technique have invented since 2004 and published in 2016 by Dr. Prasan Tangchaturon Lasami. I have learned from him since my residency training at Chulalongkorn University. We have called the technique is low-Z plastic BSSO. In the publication in 2016 demonstrate the osteotomy line. The horizontal osteotomy line start from retromolar region, which consider lower than Hansuk and Efker modification. Sagittal osteotomy continue to second molar area, and vertical osteotomy, same as the previous one. Dr. Prasan modification or rosiplasty was reported to correct the severe skeletal teeth opened by with a large mandibular setback. I have an experience on the ROSI technique, and I have noticed that we can preserve the airway dimension even in a large amount of mandibular setback. However, I have seen that the ankle width was wider after surgery. In addition, there was bony interference at the proximal segment that the blue arrow has pointed. So I have consulted and discussed with Dr. Prasan to modify the ROSI technique. I have tried so many modifications until reach the solid technique called NM-LowZ technique. The report had described NM-LowZ osteotomy technique with skeletal teeth patient. The horizontal osteotomy was started at the lingual side of the tip of the lithomolar triangle that external and internal oblique meet together. The surgical cut was extended laterally from the tip of the lithomolar triangle along the external oblique until it reached the buccal alveolar bone of the first or the second mandibular molar. The vertical cut was made vertically to the inferior border of the mandible. After splitting the mandible into proximal and distal segments, the inferior nerve should be identified and preserved. The inferior nerve can be pre-examined and localized by CBCT or the CT and 3D planning like this. Okay, and in addition to osteotomy line, I have trimmed the lingual surface of proximal segment for bone interference reduction and useful for the bone grafting. The cutting surface can enhance bone contact area with distal segment when setting back the mandible. The NM-LowZ has been done in patients more than 600 cases, both OFA and SFA skeletal 1, 2, 3. I have concluded advantage of NM-LowZ technique are the interoperative surgical removal of third molar and large setback enhanced with SFA, rotational of occlusal pain, prevent larger ankle with small invasive to muscle. So let's see in detail one by one. The osteotomy facilitates surgical removal of third molar due to the osteotomy line located next to third molar, and the shorter extension of distal segment create favorable for complete the splitting. The first example case full eruption of the third molar. She was skeletal 2 and OSA with previously orthodontist camouflage patient and plan for Cotter-Cox-White MMC, and orthodontist is Dr. Ping. She is also alumni from the Changgang Memorial Hospital. I did the splitting after third molar. After molar extraction, and there was no unwanted fracture. This is 4 days after surgery. And 6 months after surgery, we can still maintain the airway dimension and skeletal stability. This is a panoramic film show normal bone healing. Next is the example for complete and partial bony infection with a skeletal tree patient treatment planning the two-jaw surgery and Cox-White rotation and large amount mandibular setback and surgery removal of all impacted teeth. The third molar was removed after NM-LowZ splitting. The tooth was sectioned to prevent the lingual cortex fracture. The proximal and distal segment can be approximate follow to the third follow the planning. And this is 3 months after surgery. And next advantage is its ability to last mandibular setback and MMC rotation, including surgical stability. The distal extension arm of the distal segment is shorter than conventional BSSO or the Hansuk or Efger modification that can increase the amount of mandibular setback. In addition, there are less interference while the MMC rotating. The case was skeletal tree, and planning is the mandibular setback and genioplasty. This is the result. We can set back the mandible along the occlusal plane without sacrificing the airway dimension. You can see the airway dimension is not sacrificed. We have studied on finite element analysis, compare what happened between NM-LowZ and Hansuk Efger technique. She is Dr. Oravi Damlong-Wanis. She is my master degree program student. She graduated 3 years ago. This finite elements fitting up setting up system was mandibular setback and fixation with many pairs screw and one bicortical screw at both sides. We found interesting result of the maximum 1 millistrate magnitude for the NM-LowZ mini page was lower than that for the Hansuk Efger model in all state of bone formation post-surgery. The state distribution located at the middle area of the mini page. This of my arrow. The post to the osteotomy line due to the first week post-operation in NM-LowZ model and is decreased in 3 weeks and 6 weeks post-operation, while HE model have the distribution pattern on along mini page and is remained almost the same in 3 weeks and 6 weeks post-operative. Bone state is a state on bone around the screw hole. The bone state for the functional side of the NM-LowZ approach was lower than HE model or Hansuk Efger model. Therefore, the fixation for remaining in the NM-LowZ approach may have a lower risk of screw loosening and failure, and lower risk of secondary fracture in the mandible. The explanation of the lower fixation strength and bone strength in NM-LowZ is the design of osteotomy line can create inferior support like this that can help to reduce the distribution in NM-LowZ technique. And the elastic strain at the fracture site indicated the stability of the fracture site after the BSSO procedure. If there is an excessive strain after bone fixation, it will lead to fibroblast and cartilage differentiate, resulting in the bone formation failure. Even though the elastic strain of NM-LowZ technique show a bit high, but for both technique is in the range of optimal strain for bone healing. And the relative distribution value between the distal and proximal segments in the NM-LowZ approach was slightly lower than that in the HE model as on-state post-operation. The displacement at the point B was in the forward and upward direction. This implies that the post-operative distal segment will be displaced in these directions. So when we set up the MMC occlusion, we should consider to compare for the relapse. This case demonstrates what's planned for a huge amount of mandibular setback and coxswain rotation with surgery-first approach. The orthodontist is Dr. Ek. He also Chankang alumni from Department of Craniofacial Orthodontics. The plan was mandibular setback around 15 millimeter and coxswain MMC. This is the result 1 month and 1 year after surgery. We can still maintain the airway dimension and skeletal stability even at the bone. And we also have study on finite element analysis of mandibular advancement in Schedule 2 patients comparing what happened between NM-LowZ and Hansuk-Esker technique. And she is Dr. Sukumar. She is also my master degree program student. He just graduated. The state distribution pattern shows similar result with a mandibular setback model that the highest stress occur on the first week and is what at the middle of mini pain and the gradually decrease in NM-LowZ model. In summary, the state distribution was comparable between NM-LowZ and Hansuk-Esker model. This case was skeletal to vertical maxillary access and have a gummy smile, and she have a problem about OSA. The orthodontist is Dr. Ping. We plan counter coxswain and counter coxswain MMC and advancement mandible. This is the planning. This also emphasized that NM-LowZ can also be applied for mandibular advancement and counter coxswain MMC. And this is for the 6 months after surgery post-operative CBCT. Next advantage is friendly to mandibular yaw rotation and prevent larger angle width. Typically, when we do mandibular setback, the angle can be widened like this animation. Even when facial asymmetry, cases that require yaw correction also create bone interference and top condyle like this, and maybe require posterior bending cutting. But the modification that trim the lingual surface can prevent such an interference. After trimming, we can approximate the segment without top condyle. The example of skeletal tree with facial symmetric case. The submental vertex will show large bone interference of both sides. Also, the large amount of mandibular setback. And this is soft tissue projection of surgical planning. And this is result after surgery to jaw with the NM-LowZ technique. Note that the angle width did not widen. The follow-up CBCT complete healing and the condyle are maintained in position. The patient did not report TMD problems. The X-ray showed normal healing. The facial profile can correct and maintain harmonized face. And next is a severe facial asymmetry. The orthodontist is Dr. Nun. She also Shankang alumni from Department of Craniofacial Orthodontics. We planned for 2 jaw surgery. The mandible was asymmetrical setback. The submental vertex will show large bone interference of both sides. This is the result by NM-LowZ technique, which not affect the left proximal segment and condyle. At 6 months, the bone healing progressed normally. The airway dimension also maintained with harmonizing facial profile. The patient's smile is much more pleasant and happy. And this is another case for facial asymmetry that can keep the angle width. That is considered very important concern in the female patient. And after 1 year surgery, the stability is still in acceptable range. Another advantage is less muscle injury. Since the osteotomy line is lower than conventional, the incision can be modified and preserve temporary tendon. The patient can resume function early. This is a short clip video. One of my patients, he took a short clip from me to see that he is very satisfied with immediate post-operative condition. This is a 2-day post-surgery. And this is taken 1 week after surgery. He can get back to routine life and work very early. And this is 2 years after the surgery. The stability is still in an acceptable range. Okay, from my 8-year clinical experience and mechanical study of the NM-LowZ BSO can be considered as one of mandibular osteotomy technique with a facilitated surgeon in many aspects, as well as the immediate recovery of the patient and predictable of stability results. In this occasion, I would like to thank my orthodontist team and supportive staff for taking a good care of our patient. This is my orthodontic team, and as well as a Thammasat University team. And we have organized the Thammasat Orthodontic Surgery Conference, which welcome surgeons and orthodontists to share experience for orthodontic surgery. And this 28 to the 30 August, it is our great honor to welcome Professor Ellen Ko, Kim Lin, and Eric Liu from Shankang Memorial Hospital and Mai Leung from Hong Kong University to join us the third Thammasat Orthodontic Surgery Summit. Okay, and thank you for your attention. I would love to welcome any comment and discussion. I have post my personal Facebook and Instagram QR code. Please feel free to contact me. Okay, thank you.